Hello and welcome to this author interview. We're continuing our COVID-19 series. This is Howard Bachner, Editor-in-Chief of JAMA, and I'm here with Dr. Michelle Gong, who's Chief of the Department of Critical Care Medicine, the Division of Critical Care Medicine at Mount Sinai in Montefiore.
Not Mount Sinai, Montefiore.
Montefiore. Sorry, I apologize. Michelle is recognized nationally and internationally for her expertise in critical care research. Michelle, thanks for joining me today.
Well, thank you so much for inviting me.
So I think the world watches New York and holds its breath. All of my friends and colleagues wish you the best. I just wanted to go over the numbers for New York City. I pulled them off the New York City Health website. As of this morning, just over 12,000 cases. That's of about 40,000 cases in the U.S. Almost 1 in every 3 cases in the U.S. is now in New York City. About 450 deaths in the U.S. And again, about 100 deaths. 100 of those deaths are actually in New York City. What's it been like the last couple weeks, Michelle?
It's been busy, to say the least, but there's also been a lot of energy in terms of planning, in terms of being flexible and being nimble and being able to respond on a daily basis to new events, a new onslaught of patients. You know, we have seen what our colleagues have done in Europe. So even before actually the first cases have arrived in New York, there's been thinking within critical care and within our Montefiore healthcare system about what we may end up facing. And some of that forethought and some of that planning ahead of time has been invaluable during this time, as every day we're seeing more and more patients with COVID coming into our hospital.
How large is the intensive care unit at
So
Montefiore?
I run 7 intensive care units over 3 campuses within the Montefiore healthcare system. Altogether, we have approximately 86 beds and ICUs, plus we have some additional step-down unit beds that we use.
And of those beds, how many are currently occupied with COVID-19 patients?
The numbers are constantly changing. As you can imagine, the situation is very fluid. But right now, I would say we're not at 100% capacity within the ICU beds, but they're rapidly filling up. And I would say approximately, more than half of them right now are COVID.
And what have been the clinical surprises? I mean, it's interesting to read about it. You read about it in our journal, all the other journals. You hear other people talk about it, but your team is taking care of patients, and I'm sure clinically there's been surprises. What have the surprises been from a clinical standpoint?
That's a great question because, as you know, actually, Montefiore Medical Center in Albert Einstein is one of the NHLBI pedal networks.
Right.
So we are actively involved in doing research on ARDS patients. And we are very familiar with the evidence-based practices with how to deal with ARDS patients. So we knew that most of these COVID patients would have ARDS. So if they're going to present to somewhere, this is about as good a place as they're going to ever present in terms of understanding how we can best take care of these patients. But even still, there are a few things about the COVID patients that surprise us to some degree. So one is that they so far tend to be very responsive to PEEP and to proning.
Okay.
So we have been actually very aggressive about proning these patients as early as possible. But unlike some of the past ARDS patients that we've had that we prone, they tend to require many, many days of proning in order to get a response. So they may improve very rapidly when they're prone, but then when we supinate them, they lose it and then they get prone for upwards of 10 days or more if need be.
Yeah, that there's been more reports about the length that some of these patients have needed to stay in the intensive care unit, which is your unit gets busier and busier is going to have tremendous effects later on. But so that's been true that you've seen that patients need to stay in the intensive care unit with very aggressive therapy for longer periods of time.
Yes, we have seen that, and we've also seen instances where they look good, they pass all of the weaning parameters, we extubate them, and we have been successful in extubating and sending patients with COVID out of the ICU. So we have definitely saved lives. On the other hand, we also see a subgroup of patients where we extubate and they look good initially and they pass all of their weaning parameters, but then they get hypoxic and require reintubation. And at a rate that is certainly higher than we're used to in seeing ARDS patients. In addition to that, those are only the type of patients that I'm talking about in the ICU. We have also been really busy and occupied with all the patients outside of the ICU in the emergency department on the hospital wards in which we're called to emergently intubate these patients and manage them. And what's a little bit different than other past patients that we have seen with pneumonias, with ARDS, is that usually with regards to respiratory failure, they oftentimes occur within the first few days, if you will, after presenting with their sepsis or after presenting with their pneumonia. But what we're seeing instead with these COVID patients is that they may come into the hospital, and some of them actually was initially treated at home, and they were doing okay, and then at around the 5 to 7 day mark, they start to get worse, and then develop respiratory failure. And the decline that requires respiratory failure can sometimes be very abrupt. It's respiratory arrest in its true form, a sudden type of hypoxia and worsening that requires emergent intubation. And we're also actually seeing a number of patients who are having cardiac arrest. As you know, there's a certain percentage of patients, quite high, that may have evidence of some kind of myocardial injury. And we already have seen some patients with evidence of myocarditis in the setting of a COVID infection. Maybe that contributes to some of these cardiac arrests that we have seen. But again, it is sudden. It is not yet predictable to us as to who will get it and who will not.
Yeah, in our very first report that we had from China, they talked about a subgroup of patients who appeared to be hospitalized and be doing reasonably well, but then 5 or 7 days later, they ended up with acute respiratory distress. A lot of information about various therapies,
Yes.
some controversial, some less controversial. You know, President Trump mentioned one or two. I think Dr. Fauci was more hesitant to broadly support any therapies. Are you using any treatments that you think you'd like people to know about?
So I think that that's a great question, and it is something that we have struggled with over the last few days, especially me, being in the position as chief of critical care. Right. A lot of these requests actually come through my my purview, and I feel very, very strongly right now that research and treatment of COVID is absolutely essential. We do not have proven therapies to treat COVID, and they are unbelievably needed at this point. Having said that, I also understand clinicians' desire to try anything, and that any reports that this might work or that might work or that it works in vitro with like animal studies, they want to try in patients. However, I caution that. And that we have had multiple agents in the past that seems to work great in animal studies or in observational studies, but then turned out to be, at best, not effective during clinical trial, but actually even harmful. And that is particularly important here in COVID, because with the onslaught of these patients who desperately need treatment, we need to test out these various treatment modalities that have been brought up, but we need to test it in a way where we know whether it's effective or not effective. It is just as important to know if a drug is not helping as it is that it is helping. Because if it's not helping, then one, we do not deprive those patients who actually need the drug for their proven therapy from these medications. Because right now we're seeing shortages of things like chloroquine, for example, just because they're being used in COVID. But also, too, is that if you don't systematically measure adverse events in patients that are this sick, it is very easy for us to do more harm with therapies that we thought might be helpful, but actually turned out to be not helpful and to actually create more side effects. So it is absolutely imperative that during this time, as everybody is desperate to look for treatment, we also need to actually evaluate these treatments in clinical trials so that we know what's helping the patients
I know
what's harming the patients.
I know you're both a clinician and an investigator, and I also do know that you're a member of the PEDAL network, but we have two viewpoints coming out specifically about this issue because of the tension, one by Andrew Khalil, which will be out in the next day or so, and then one a little later on this week by Derek Angus about this tension about trying new drugs that are unproven or people think may work, but if you do it in an uncontrolled fashion, one, you don't learn very much, and then secondly, you could do harm. And
That's
so
right.
that tension with being a clinician and an investigator at the same time. So those two viewpoints will be out later this week. Could we return to the cardiac complications that you're seeing? There's been various reports about various hypertensive drugs. And now the pericarditis has crossed my desk. Could you say a little more about these issues and these patients?
So that is another one of those areas in which we do need research, because what we are seeing is that a certain percentage of these patients have elevated troponins. We also see actually some of them have decreased heart function. We see also arrhythmias. Such as atrial fibrillations. And like I said, we've seen evidence of cardiac arrest. Okay. Now, it's possible that the arrhythmias we're seeing and the troponin that we're seeing may just be a reflection of critical illness, because we very much are familiar with patients with sepsis that before the COVID pandemic had elevations of myocardial stress and injury with release of troponin. And we also have known about Takashimbo, something that we have seen in patients who are very sick in the intensive care unit. So it's still not yet clear, actually, if COVID-19 in and of itself confers a separate, more lethal, or more functionally important impact on the heart than, say, severe critical illness that we have seen in the past. But it just highlights to you, actually, some of the clinical problems that we're seeing, but also some of the unknowns in which we're operating in right now.
Another topic that comes up often is the age distribution. Clearly the early reports from China really identified older age comorbid conditions, particularly with hypertension, at being a much increased risk for mortality. Some early reports from the United States, particularly New York, indicated that more younger people were being hospitalized. I don't know the data specifically for intensive care units or severity of illness. Could you comment about what you're seeing with respect to age? I appreciate that may reflect the area in which your ICUs exist, but it also would be interesting because you're a clinician seeing patients.
Yeah, and I'm also an epidemiologist and investigator.
There you go.
So I will always caveat these personal anecdotes as well as observations with the fact that we need actually large epidemiological cohort studies to understand exactly what is the effect size that we're seeing. Observationally, from our experience here at Montefiore, we are seeing young patients that need to be hospitalized for COVID-19. Unfortunately, we are admitting young patients in their 20s, 30s, to the intensive care unit, and some of them are quite sick with ARDS.
Do you have
Having said that, though, I would still say that the predominant number of patients in which we're asked to see, to evaluate, to take care of for critical illness are still the elderly patients, the patients with comorbidities, and the frail elderly patients with poor functional baseline. And they oftentimes also present with multiple organ failure.
How have you organized your staff and the nurses and the other healthcare workers that have to work in the ICU? This has become a huge issue. And how are you dealing with older staff?
Yeah. So this is where actually the leadership from our institution, as well as actually the truly heart-inspiring dedication of my colleagues at Montefiore has really given me a lot of inspiration to continue to do what we do. So the clinicians and the nurses and the respiratory therapists have all stepped up. That is in spite of some of them getting sick, and in spite of some of them actually doing multiple extra shifts. So they've all stepped up to do more, to do it longer, to do things that are, a little bit outside of our box. So now is our time to try to be creative in terms of figuring out how best to take care of these patients, and to be able to do so on an unprecedented manner. So what we have done is basically all hands are on deck. We have pulled clinicians from wherever they might be to help in the best capacity that they have. And I'll give you an example. My anesthesia colleagues has been nothing short of phenomenal during this process. As the elective surgeries have been stopped, they're now a group of people who have unique skills that may be particularly helpful during this pandemic. And they have really been stepping up and so incredibly supportive of what critical care and the hospital needs, but also so incredibly helpful in their suggestions of how do we function in this crisis mode? How do we do what we need to do to meet the needs of the patients? There have been volunteers to help in critical care, to staff new units that we're building. There have been volunteers to even just work on the hospital service from other kind of departments and divisions, because the hospital inpatient service is also actually seeing a huge volume of COVID patients. So it does take actually not only dedication from the staff, but also for planning from the institutional leaders, which we have been very fortunate to have, but also actually the ability to think outside the box a bit and think, what can we do to uptrain some people and match people with their different skill sets to something else that they can do in which they can still help with the pandemic and our response to the patients.
Testing, PPE, and ventilators. It's on the front page of the newspaper every day. I think we don't have to go over the fiasco that has been testing in the United States. Availability of PPE, and in part the inability to test, has led probably to more complications around the use of PPE and then ventilators. How's Montefiore doing with testing, PPEs, and ventilators?
So in terms of testing, it's been actually an escalating process. Meaning, we started off like all the other hospitals in which we had to send our testing to the DOH. But it became increasingly clear to us actually that was just not going to be adequate if it was going to take days, and that this could actually impair our ability to rapidly treat these patients. So our hospital epidemiologist, Teresa Maline, as well as the hospital leadership here, has worked tirelessly to bring testing on site, and that has changed the game.
Yeah.
The ability to actually test COVID on site and be able to turn around made it much more important as well as efficient in both being able to get the patients what they need, being able to have timely PPE, but also to save on PPEs.
Right. Right.
Okay. That is just as important because
Right.
we're no different than any other institution in the United States. We're still struggling to make sure that our healthcare workers have the adequate PPE. And I cannot tell you how important that is, not only to me, but to all of the institutional leaders. This is like a topic that is constantly on every discussion at every meeting that we have, to try to be able to make sure that our health staff, our clinicians are getting the PPE, the nurses and the respiratory therapy are getting the PPE that are needed. And it's also a challenge because communication is an issue, right? Because the DOH and the CDC have also changed some of their guidelines. So in our ability to try to communicate with our teams about what those changing guidelines are in the midst of the PPE shortages, you always constantly have to make sure that we're communicating, no, these are consistent. We believe that this is still going to be helpful. These are the changing guidelines of the DOH, and not necessarily that, we don't have enough and that, you need to do without. And we've been fortunate, I don't deal with the PPE. I have other things to deal with, but there are people who actually have spent all of their time at Montefiore basically procuring PPE. So right now we actually have the supplies.
Right.
But it's took a lot of work from some very dedicated individuals within the Montefiore healthcare system to be able to get what we need right now. But it is a problem, not just for us, for everyone.
Yeah, I think one of the points that you made, which has been reiterated in my conversations with people, is for hospitals who think they're prepared, they cannot outsource testing. Testing must come in-house where you can get timely responses, not in a matter of days, but in a matter of hours, because it becomes a logistic nightmare if you actually don't know if the patient has COVID-19.
No, absolutely. And that means not only being able to get the technology in-house to test it, but it means that you have to make sure that you have enough staff in the laboratory system, that you have a pipeline for the reagents, that you have adequate training, all of which actually I don't have to deal with. But fortunately for me, my institution had people to deal with that and got that all done. We basically went from no in-house testing to being able to do hundreds of testing within maybe about 3 days period of time, partly because they anticipated and they rapidly escalated. But I agree with you. It is urgent, and it is imperative for all institutions to consider now.
Yeah. A couple questions are coming through that I'd like to go over with you, if you don't mind.
Sure.
Non-invasive approaches to ventilation.
Yeah, so that comes up quite a bit. And in full disclosure, I actually co-author a clinical practice guideline for treatment in COVID that was published through an ICM. That's a joint venture between SCCM and ESICM.
I don't mean to interrupt, but we're going to have a synopsis of that guideline published in the next day or so. It's very, very important. And we're going to have an editorial that accompanies both the synopsis and reflects on that guideline. But go ahead.
So along those lines is one of the questions that we had tackled was the use of non-invasive ventilation. And that pertains not only to BiPAP, but say high-flow nasal cannula. So there is a concern that non-invasive ventilation as well as high-flow nasal oxygen is an aerosolizing procedure that might increase the risk of transmission of COVID to the healthcare workers. On the other hand, you have to balance that risk with the risk of intubation, which we know from SARS have the highest risk of transmission of viruses, given that it is a very up-close aerosolizing procedure. Right. So what we did in that review was that we tried to evaluate the effectiveness of these interventions, the non-invasive ventilations, on either increasing survival or decreasing intubation rate and balance that out with the risk of transmission of virus. Okay. And what we recommended was that there is, especially with the acute hypoxemic respiratory failure and ARDS that we see in patients with COVID-19, that high-flow nasal cannula has been shown to decrease the rate of intubation. And even though the data is not strong, meaning that there's just not an awful lot of data on high-flow nasal cannula and risk of transmissions, what we do have on that data seems to indicate that a high-flow nasal cannula does not confer any higher risk of transmission of viruses or of infection compared to, say, conventional oxygen therapy. So for those reasons, we do recommend actually a trial of high-flow nasal cannula in patients who don't need to be emergently intubated, to see if you can actually decrease the risk of intubation, because that actually confers a higher risk of virus transmission. And there's also some meta-analysis to indicate that you can improve mortality with averting the intubation with a high-flow nasal cannula. On the other hand, non-invasive ventilation like BiPAP has not been shown in the same...
That's all right if you have to go off camera for a second.
Sorry. It has not been shown to decrease the rate of intubation in patients with ARDS. Meta-analysis that has shown that there may be a benefit. A lot of that data is driven by trials of patients with postoperative respiratory failure, which is not really the patient population that we're talking about now. However, in select cases, like if, let's say, is a COVID patient who also have COPD exacerbation or who have pulmonary edema, because those patients still come. There's still patients with COPD, and there's still patients who have heart failure who come into the hospital, and they may be concomitantly infected with COVID. Maybe there is a role in that, but I wouldn't say that it's a strong recommendation by any chance. But irregardless, whether you're using a high-flow nasal cannula or BiPAP, you should absolutely consider not waiting to the last minute to intubate these patients. An emergent intubation probably has the highest risk of potentially contaminating the healthcare workers.
Questions about ACEs and ARBs have come up. There's two separate questions. The first is for the population at large. If a patient happens to be on those drugs, does it increase the likelihood that they'll get COVID-19? That is an unanswered question. And then the more relevant question in the intensive care unit or in the hospital, is it inferring a greater risk of mortality? So how have you been handling the ACE and ARB question?
So we've been handling it the way that we have handled it with all of our critically ill patients, even before the COVID-19. Because as you have indicated, we don't have the data to tell us what to do. So when we have a patient who with COVID-19 who is hypotensive, who has borderline blood pressure, we do like we've always done, which is that we hold all of the antihypertensive, and that includes the ACE inhibitors and so forth. And most of the time when they're admitted to our ICU, they're not necessarily hypertensive, so we don't necessarily need to give them the medications back. The exception sometimes is some of our patients in our comprehensive stroke center. They are coming in, now we're seeing patients who are coming in with acute strokes, and in the process actually also turned out to be COVID positive. And now there is an indication to control their blood pressure, right? So in those cases, we've been using drips and other alternative medications to be able to control their blood pressure.
Couple epidemiology questions. I know you're an epidemiologist. The patients going home, where are they going? The patients who you've gotten ready to discharge, where are they going?
Home.
They're going home.
Yeah. So it depends. When patients are able to go home, that is still the preferable place. So they'll go home. We do have problems about those patients who are not ready to go home, and whether or not they can be taken to a rehabilitation center, for example, or a nursing home. And we are working with our colleagues in those care facilities to try to facilitate that process. But it's hard. They are afraid to take, COVID patients back. But at the same time, we need the room in the ICUs. So we're working actively with that. But our preferred locations for these patients to go back is to go home.
As more masks have become available in the U.S., it's once again the debate about whether people in public or staff should wear masks all the time. There's been some suggestions that in Singapore, Taiwan, and Korea, the wearing of masks at least reduces the amount of times people touch their face, which is an interesting issue.
Yeah.
And I'm wondering if you have an opinion about masks. It was widely reported, I still follow the Boston papers, that Partners had begun to recommend that all of its staff wear masks. And I'm wondering if you'd feel comfortable commenting about that.
So I feel that masks should be reserved for the healthcare workers. They're the ones at the front line of taking care of these patients. And first and foremost, they need to have an adequate supply of PPE. If we get to a stage where, there is enough mask for everyone to go around, a surgical mask, then I think I'll leave it to my public health expert to decide actually where that might be most usefully implemented. But it's mask, it requires people to understand how to use it. It's not just because you put on the mask and you'll be instantly protected.
Right.
Because I cannot tell you how many times on the streets of New York I see people wearing masks and they've pulled it down past their chin, or that I see them constantly reaching underneath the mask to scratch their nose. So just having the mask is not a magical elixir that will create a bubble of protection around you. If you don't use the mask in the right way, it's even worse. You contaminate the inside of your mask, and then let's just constantly rub the inside of that mask against your nose. It could be worse for you.
It may be early, and it's always a sensitive question, and then I have just one or two after that, or one or two observations. There's been quite a few questions about case fatality rate. Can you comment?
The numbers are constantly changing. So I don't think any number I give you is, one, a guess, and two, will probably be wrong by tomorrow.
Okay.
So I don't know how best to answer that. We have seen mortality. We have seen very sick patients. But right now, between the increased number of patients that are being tested and the fact that actually many of our patients are in the hospital for a prolonged period of time, I just don't know what the actual case fatality rate, not just at my institution is right now, but across the board, because it's constantly changing.
So, you've really been involved in the care early in the United States. We have very sophisticated intensive care units all throughout New York City, Boston, Seattle, some in San Francisco. But many, many parts of the country have been spared the onslaught of intensive patients who need intensive care. What are the 2 or 3 recommendations you'd give to your colleagues?
So one, I don't think anybody will be spared. I think the COVID is here in our population, and it's a matter of when it starts to percolate through the community. Maybe you won't get it in the first batch, but maybe in the fall or the winter you'll end up getting it. So we need to learn from our colleagues in Europe. We need to learn from our experience right now, both, one, how to prepare, two, how best to treat these patients, three, how to escalate. If it turns out actually mitigation in your particular region or area is not enough to dampen the flow of patients, and how you would be able to escalate and respond if need be. That takes some uncomfortable planning ahead of time for developing situations, but it's never too early to start that.
Okay. This is Howard Bachner, Editor-in-Chief of JAMA, and I've had the privilege of being joined by Michelle Gong, who's a professor of medicine and chief of the Division of Critical Care at Montefiore Medical Center. Michelle, to you and all of your colleagues, please stay healthy, and thank you for spending the time with me today. Thank you.
And to everyone out there, we wish the same for you. Stay healthy, take care of yourself, and take care of those clinicians and the healthcare workers that are taking care of the patients with you.
Thank you. Bye-bye.